My name is Dr. Andrew Koch.
I grew up in Park Ridge, New Jersey.
I went to medical school at Penn State at Hershey Medical Center.
I'm Paul Leslie.
St. Joe's University.
I'm Ed Fearnow.
Bath, United Kingdom. Hahnemann University.
Cindy Janeski.
I grew up in Lancaster County.
John Garofalo.
Harvard Medical School.
My name's Rebecca Pennell.
Plain, Virginia.
I'm Dr. Bob Latshaw.
University of London in England.
Alex Feinstein.
Pittsburgh, Pennsylvania.
I'm Dr. Patel.
Harrisburg, Pennsylvania.
University of Maryland Medical School.
Dr. Singapuri.
Johnstown, Pennsylvania.
The University of Michigan.
Born and raised in Lancaster County.
My name is Nitin K.
To medical school at Hahnemann University and did my residency training at Mayo Clinic in Minnesota.
Hi, I'm Bob Still, Practice Manager of Lancaster Radiology Associates. LRA is a dynamic medical group of 33 diagnostic and therapeutic radiologists. LRA provides a vast array of services to Lancaster General Health, from X-ray to advanced imaging to women's imaging and radiation oncology. These impressive physicians serve Lancaster General Health with dedication, cooperation, and medical excellence. With a vast range of medical training, experience, and knowledge, a radiologist is at the forefront of the diagnosis and treatment of disease. With the use of cutting-edge technology and treatment methods, many people call these physicians lifesavers. Today we're going to take a look at the 40-year history of Lancaster Radiology Associates and the mutually beneficial relationship that they have had with Lancaster General Health.
The LRA was established in 1971, and it was done because at that time the American College of Radiology and other professional organizations were urging radiologists and other hospital-based physicians to go on separate billing for their services, so they were not perceived as super technicians, nameless and faceless, but they were physicians.
St. Joseph's Hospital and Lancaster General Hospital were neck and neck in leadership roles in this community for healthcare. And one of the catalysts that drove Lancaster General ahead of St. Joseph's back then was the radiology department.
It's hard to separate imaging and radiology from taking care of pulmonary and critical care patients. And in the pre-digital era, we used to go down to the basement where we would request a film. After a period of time, we'd get the film and walk into this dark room, affectionately known as the pit, where there could be as many as 6 radiologists working. And there was an opportunity to talk about a lot of things, including the patient. And we would show the films, and the radiologist would weigh in on what their interpretation of the film was, and also what they thought should be done for the patient. And it was a great opportunity for collaboration.
Physicians that had volume practices required a lot of help, a lot of support to develop their programs and to be the efficient physicians that they needed to be to deliver good health care. And the radiology department worked 24 hours a day. They were enduring physicians who had a great deal of talent, energy, and were always made available to all of us. And that availability and their good performance enabled us as clinicians to deliver more efficient and more expeditious care to patients in this community.
When I first entered radiology, there was just radiology, diagnostic and therapeutic. All the other sub-disciplines appeared since then. And in fact, somewhere along the line, I went to the administration and said, look, we've added nuclear medicine, we've added ultrasound, we've added angiography, we've added neuroradiology, we've added CT. We're not just radiology, we should be the Department of Radiology and Diagnostic Imaging. And they agreed, and that's what it's been since.
Our commitment to quality is exemplified by the fact that Lancaster Radiology Associates has in the past and continues to recruit fellowship-trained radiologists into the practice. Fellowship training means that the individual had additional training beyond the 4 years of radiology residency in a specific area of radiology. For example, our practice has neuroradiologists, radiation therapists, interventional radiologists who received additional training to treat and to diagnose complicated diseases that are not treated by surgery. So we have musculoskeletal radiologists who basically studied disorders of joints and bones and soft tissues of the body. And in addition, we have fellowship-trained individuals in all the separate modalities of radiology.
The practicing gastroenterology, as probably practicing any aspect of medicine, would be impossible without radiology. They have a wide variety of diagnostic services. From our point of view, they do a lot of ultrasounds, a lot of CAT scans, a lot of MRIs. But not only do they do diagnostic services, they also do a lot of interventional work.
The many faces of diagnostic and therapeutic radiology are called subspecialties. A radiologist training now includes a 5-year residency program after medical school, and many of the LRA physicians have an additional year of training or a fellowship year in a specific subspecialty of radiology.
X-rays literally represent the first form of medical imaging. It started in the late 1890s, about the same time Lancaster General was being made into a hospital. A patient comes in and they may have fallen, and they've fallen onto their wrist and they have pain. The technologist will bring them into the X-ray room. They will position the arm in 3 different obliquities. X-rays always require at least 2 different views to diagnose a fracture. What happens is the technologist takes the images, and in today's world, they're picked up by the computer and sent right directly to our desk, where we look at the images, we dictate a report, and if it's fractured, we call the report to the referring physician. The most common way that we use X-rays today, we image bones. We look at fractures, we look at arthritis, we image every joint in the body, we image the spine. The most common diagnosis in almost every hospital is congestive heart failure. The first line of diagnosis and treatment represents the chest X-ray. Without X-rays, we would be in the dark ages.
Ultrasound images are produced by transmission of high-frequency sound waves into the body. These are reflected off of the organs back into a receiver at frequencies that are characteristic of the organs. We image the thyroid gland and the kidneys and abdomen, gallbladder, the bladder, prostate gland, scrotum. The data is processed by a computer, and ultrasound images then are projected on a TV screen. Ultrasound is different in several ways from our other imaging procedures. The major difference and benefit is that there is no ionizing radiation. So that, just sound waves, which typically have no proven bioeffects. So this is less invasive, and it is painless. Another advantage of ultrasound is that the real-time pictures can be viewed on the screen, and the movement of the organs and the movement of blood flow can be detected.
You can see the heartbeat.
Ultrasound is used very much in the medical diagnostic care of women, mainly because the technology has evolved to the point where extremely accurate, detailed images can be obtained of the uterus and ovaries.
Our primary modality, which is still the mainstay of imaging the breast, is mammography. That is the most cost-effective way to screen a lot of patients for breast cancer. Adequate screening does decrease mortality from breast cancer. Each year, about 40,000 women die of breast cancer. Abnormalities in the breast can be seen in a number of different ways. They can be seen mammographically, and we have the capability to do biopsies of these abnormalities using mammographic guidance. This is called a stereotactic core biopsy. We also can do ultrasound-guided core biopsies of breast lesions. And in the past 2 to 3 years, we've also been doing breast MRI-guided biopsies. There are often lesions we see specifically only by breast MRI, but cannot be seen by mammography or ultrasound. Those lesions we can biopsy with MRI guidance, and we have a specialized team that is capable of doing that. One of our senior-most radiologists is Dr. John Garofalo. In fact, this room that we're sitting in has been named after him because of his dedication to mammography.
I had had a lot of training at Jefferson with a fellow named Steve Feig, who became one of the gurus in mammography. And we were part of the initial national screening program called the BCDDP project, which was a project that screened women, and they had over 50,000 women which were screened. And they compared them to controls to see whether mammography was saving lives. And it turned out that it was.
It is a pleasure to have John review a case or to be interacting with him on a case and a particular patient because of the vast experience, greater than 30 years, that he brings to the table.
Nuclear medicine is that part of diagnostic radiology where a radioactive material is injected into the body to image a particular part of the body that we're interested in finding out what's wrong with the patient. What typically occurs is a radioactive material is binded to a specific agent which goes to a particular organ that we're trying to image. There are many uses for nuclear medicine. For instance, one of the most common uses in nuclear medicine is a bone scan. In that particular case, a radioactive agent, usually technetium, is labeled to a bone agent. It's a phosphate. That's injected into the patient. The patient's then scanned a particular time later, and the entire body is scanned. What we're looking for typically is often metastatic disease for any type of cancer. The whole body can be scanned, and we look for hot spots. Hot spots are typically areas of cancer that are metastasized to the bone.
At Lancaster General, we provide CT services 24/7, 365 days a year. A CT scanner is a donut-shaped X-ray device where the X-ray tube spins 360 degrees around patients and takes a 2D slice. The scanners, when we originally started, would take a single slice at a time. Current scanners will scan up to 64 slices at a time. We currently have a total of 9 CT scanners in our system at 7 sites. We currently do over 90,000 CT scans a year. CT is used throughout the institution for essentially all services. All trauma patients get CT scans when they come in. We're used to diagnose myriad musculoskeletal problems, abdominal problems, neurological problems. It's used in place of conventional angiography now. It allows for much more precise diagnosis.
I believe in Lancaster Radiology.
I believe in
I
Lancaster.
believe in Lancaster.
I believe.
I believe.
I believe in the future.
I believe in the future of Lancaster Radiology Associates.